I'm Adam Pellegrini, CEO of Jasper Health. This is an amazing panel. It's one of its first of its kind of panel to tackle the real awesome and empowering and important space of virtual care in oncology. And there has been so much going on in digital oncology, I would say in the last 12 to 24 months, especially when it comes to virtual care. We all thought, and ATA thought, it would be awesome to have a dialogue with thought leaders on the stage here about what are the learnings, what are the lessons that we've learned, where are the biggest challenges, but most importantly, where's this going? I think the bottom line for all of us on the stage, and then we're going to start with some introductions, is we have all been doing digital health or whatever you want to call it in the digital space for a long time. I know Mary Elizabeth and I worked at the Cancer Society in 2000s and early. And a lot of these things were still, in some cases, taboo topics. And we now have gotten to a place in the industry where it is an industry. It's actually a meaningful part, a meaningful business, a meaningful impact on patients. And now, because of digital, we believe it can scale. So we're going to kick off this panel and with introductions from some amazing friends and thought leaders. Go ahead.
Sure. Thank you so much, Adam. I'm Siobhan Rary. I'm a clinician by training, an endocrinologist specifically. And I've been in the digital health space for over 15 years. I moved from the patient's bedside to more operational roles, all driven by the passion to make care better. How can we improve care? How can we improve patient outcomes? And moved from more creating, building, scaling large national digital health programs within the health system, a national oncology network with 5 hospitals and 16 outpatient clinics, to big tech. So I moved into Amazon Care within the Amazon space, where we were looking at virtualizing primary care with an in-person component. And in my most recent role, I'm serving kind of more upstream as a venture partner at Takeda Digital Ventures, where we invest in virtual first digital companies, care delivery companies or care enablers. So really excited to be here, Adam, and to speak to you all about oncology within the telehealth space. It's been a passion of mine. Thank you.
Okay, great. Hello, everyone. I am Tiffany Avery. Adam, thank you for the invitation. Very excited to be here. I am the Chief Medical Officer of Nant Health. I am a medical oncologist by training and spent the first part of my career in academic medicine, actually. In academics, I was a breast-dedicated medical oncologist, and so in that role, I ran clinical trials, but also did a lot of population health and disparities work. And in my role as an academician and a clinician, I got very interested in how we can take care of the patient with all of the aspects of good cancer care that happen outside of that space that I had in clinic. And so, of course, taking care of a patient is very complicated, and a lot of what we do in the clinic in terms of getting the person on the right treatment is the first step. But then you have to make sure they're able to actually get the treatment that you want them on in a timely way, in the right way, and complete it so that you realize the full benefit of the treatments. And so I might be the newest to the digital oncology space. I've been at Nant Health for 3.5 years now. And really my interest is just that, on how we can support the patient getting through their treatment, all of those aspects that we know need to happen in addition to what happens in the office. And then how can we support a patient through the entire cancer journey? So everywhere from screening and making sure screening is happening in the right populations, genetic testing when it's applicable, all the way to how can we support patients at end of life and palliative care choices. So thank you. I'm excited for the discussion today.
Thanks, and again, thanks for having me as well. My name is Mary Liz Rich. I serve as the president for the CEO Roundtable on Cancer. We are an enterprise that, while we are a nonprofit, we are more of a think tank collaboration to do things that companies can't do and shouldn't do alone, all for the benefit of the patient, or for the survivor, or for the future patient, thinking of it in those terms. We have two different sides of the equation, and that is we have our clinical trials research database, but today's focus that we're really accelerating here is our accreditation model, and that's our gold standard, of which Jasper Health is a proud gold standard accredited company. They're also a member of the CEO Roundtable, and they bring in that technology fold, as we have a lot of life science members, we have some health system members, we have retail health and financial, and Jasper Health certainly brings in that technology fold. But more importantly, the accreditation piece and how that functions is very critical in telemedicine today, because of how we started as an enterprise was at the bequest of then former President George H.W. Bush to the employee CEOs, a call to action to the CEOs to do something about oncology care by starting with their employees and making it possible for them to access the best possible care, prevention, early detection, support them in survivorship, overall general personal health and navigation. And that brought us to an accreditation platform that is not an award, it is an accreditation that helps companies with their policies, navigating their policies, their benefit packaging, be it if they are supported through payers or if they are trying to create a self-insured model. So certainly telemedicine, the virtual aspect, that certainly at the end of the day, employers, they want to decrease their overall cost while not sacrificing care. Telemedicine is able to help bridge that gap for them, and also certainly make sure that productivity stays up, as well as retention stays up, and employee, most importantly, their health.
Hi, everyone. Pleasure to be here. My name's Cole Manship. I am, I've been in the digital health space for about 12 years now, basically the entirety of my career. I'm currently the Director of Product for MSK Direct, which is a virtual oncology support solution from Memorial Sloan Kettering Cancer Center. So for those who don't know, Memorial Sloan Kettering is the leading cancer research institution in the country. It's been named number 1 or 2 in terms of cancer treatment in the country for the last 30 years. It's the oldest, largest private cancer treatment and research center in the country. And MSK Direct, we support individuals anywhere in the country with various services to make sure they get the right diagnosis, they're on the right treatment plan, and they have the necessary support every step of the way throughout their journey. We make the service available through large self-insured employers. Since launching in 2016, we've grown very rapidly. We now have over 150 self-insured employer clients. Collectively, they cover about 6 million lives. Pleasure to be here and looking forward to this conversation.
Well, fantastic. Thank you. I mean, as you can see, truly some of the leading experts in this space, and some themes that you can also hear, that you've heard in other parts of telemedicine, and especially in other discussions and panels around employer support for virtual care, specifically in oncology. One of the top interventions that I have read about, and clearly much more experts on the stage than I, from a clinical perspective, is delivering second opinions, and really how can that be virtualized as a best practice in the employee and payer space. And what do we think is the promise of that virtual second opinion and remote patient monitoring? And I would love anyone to just jump in on that one.
I'm happy to jump in there, since virtual second opinions are really the foundation of the MSK Direct program. Outcomes vary significantly in the United States based off of the care setting where a patient is treated. At the top NCI designated cancer centers, survival outcomes are significantly higher than they are for patients treated in community hospital settings. But unfortunately, almost 80% of people receive their diagnosis and their treatment in community hospital settings. So the promise of virtual second opinions is it takes that expertise that's housed in a few medical centers, primarily in large cities, and it makes it accessible to patients and their local treating doctors anywhere in the country. You know, having the right treatment plan starts with having an accurate diagnosis. And in MSK Direct, we're able to get a patient's pathology tissue sent to Memorial Sloan Kettering and reviewed by subspecialized pathologists at Memorial Sloan Kettering to make sure that patient has the most accurate diagnosis. And then that diagnosis and the patient's medical records are all provided to a medical oncologist who's subspecialized in that patient's unique disease. And they're able to provide a treatment plan as if it were a Memorial Sloan Kettering patient that they were seeing in their clinic. That treatment plan goes to the patient and their local physician, and you know, in the ideal situation, they're able to implement that care plan locally, so the patient doesn't need to leave home, or doesn't need to leave their care setting.
Yeah, and if I could add to that, Cole, so I'm glad you brought that up, because that's absolutely right, that most cancer patients are not treated at academic settings. And so you mentioned getting the right treatment plan, absolutely. And I think the other promise of digital oncology and virtual help in this space, if you will, is what happens to supporting that patient who's in the community, right? I practiced in academic settings as well. I did my fellowship at Anderson, so we were chuckling that we're always one and two, we battle it out. But, you know, if a patient is at an academic center, they have all those supports usually there, right? So there's navigation to help them keep track of their appointments. There's any financial counseling that they need. There are counselors to help with social determinants of health and, you know, nutrition and all of these aspects. And so how do you replicate all of that as well, right? Once they get the right treatment plan, making sure they can stay on it and totally have the transportation that they need and all of those supports. And so for me, that's what I'm most excited about in working in kind of an end-to-end space where we can support the patient that way. So
absolutely.
Siobhan, from a provider, I mean, it's almost like this new generation of virtual oncology. It's going to take a blend of skill sets of being a provider, a product expert, a digital expert, and an expert in scaling. And I know you have done incredible work in scaling virtual care and really bringing providers into in multiple jobs that you've had. What do you see as some of the biggest advantages and challenges?
Adam, I think that's an excellent question, and I think I can start by suggesting asking a few additional questions in addition to that, just to get the thoughts moving. So I ask the audience, why is it that Australia spends less per capita on cancer care than the US, and while having improved or lower mortality rates in all-cause cancer than the US? Or why is it that Finland can have an individual see an oncologist in half the time that the US can? And I think the answers to that is more complicated, and I'll share a personal story. About 3 years ago, my husband of 15 years and I received profoundly impactful news that changed our life in an instant. We received news that he had a 12-centimeter mass, 2 fists the size, the length, 12-centimeter mass in his left upper thigh. And it was encasing his lower extremity vein. The mass was seen on an MRI, and it had a number of blood vessels, and likely it was, highly likely it was cancer. And so our life changed in an instant. We have 3 kids. Our youngest at the time was less than 2 years old. And what did we do? I'm a clinician. I'm on the phone calling my clinical team. I'm calling my colleagues, and I'm trying to establish where can he be seen in the quickest amount of time to get him in for a biopsy, for further imaging, for us to get the diagnosis. And thankfully, we were able to get in, and within a week, we had additional imaging, we had a biopsy, and we got the results back within that week's time. And we found out that he has a very rare type of cancer, and that he would require extensive surgery, including reconstructive surgery. And so what we did what anyone really would do, anyone who has access to care would do. And so we were able to quickly mobilize, calling additional resources. We were able to have him seen at the nearest academic facility, which was a 3-hour drive from where we were. And he needed to have radiation therapy. So he had 6 weeks of radiation therapy in which he would work in the morning, take the afternoon off, drive the 3 hours to the radiation therapy. I would pick up the 3 kids, bring them home, feed them, and then my husband would have his therapy, drive 3 hours back, and he was home, and it would start the whole next day for 6 weeks. We then had my mom come, we paid for her ticket to come from Florida to stay with us during the time when my husband would have surgery. He went ahead and had an 8-hour surgery with reconstruction, and I was able to stay with him for 3 days in the hospital while he was recovering. And then he had rehab. He needed rehab 6 months after, or rehab for 6 months. And so what I ask of you all is consider if he was a single parent. Consider if he was a single dad with 3 kids. Perhaps he had transportation issues. Perhaps he had issues with getting food on the table. Perhaps he had issues with an established housing. Perhaps he had issues with language, interacting in English. Perhaps he had issues with vision or other disabilities that would prevent him from interacting with the healthcare system. Perhaps he had, as he's trying to figure out who's going to take care of the kids while he goes through the treatment. How is he going to get into the system? He doesn't have the physician wife to call and make additional concessions with friends of mine in the field to get him in seen quickly. And so this is the reality we have in the United States. And this is what has galvanized me to do better. I think us within the United States, if we look at other countries, they are engaging multidisciplinary teams. They are engaging increased access to care. They are making care affordable by national health systems and taking out all of the misaligned incentives that we have in the United States. And so this is our call to action in the United States. How can we create an experience, leveraging digital health, to create the best experience of one's life in healthcare? To just take a step back. Why would we not? Why would we not try and create the best experience of one's life in healthcare? And we have the tools to do so. So I say, Digital Health 1.0 was leveraging telehealth to provide care for urgent issues. Digital Health 2.0 was leveraging care for chronic disease management or primary care. I think we're on the precipice of Digital Health 3.0, Jasper, being able to take complex care and transform that with digital health, with hybrid care, and really create those opportunities for a seamless, multidisciplinary experience for mental health, for social determinants of health to be identified, and for resources to be articulated, so we have a better healthcare experience for all. And so this is what I envision, and this is why I'm in the digital health space.
Wow, I could literally not follow that. I'm not sure what I might have to start talking about something else because that was so perfect. But I will say something that you talked about, and it's hit home to me ever since I came over to work at Jasper, is we have an advisor to Jasper who is living with cancer today. She wouldn't say she's a survivor. She wouldn't say she's in remission. She would say she's living with it as a chronic disease. And week one, I sat down and had a real great dialogue with her. And I said, what would you do? What would you do? And she said almost a similar story. She had access to all the greatest oncologist you can imagine. She was in the Silicon Valley area, so she had access to everything from everyone. And she told me a story that it stuck in my head, it sticks in my head this day. And she said, Adam, she goes, I have access to everything. I can get to treatment. I can have 13 oncologists on a call tomorrow to pressure test a treatment plan. And my oncologist, my main one, wanted to prescribe a treatment that would have me basically going through treatment all summer long, and I wanted to go on vacation with my kids because she had stage 4 colon cancer. Life is so important to her, and spending time with her kids is every day matters. And she said this treatment plan made it so that I was locked down basically into this one treatment all summer, and I couldn't do this trip with my kids. And my friend, who is an oncologist, an expert, said, well, why didn't your oncologist just say this treatment option? This would let you do it periodically. You would still you would go on your vacation, spend time with your kids, and the outcomes are the same, and you're a perfect candidate for it. And she goes, I don't know, I'll ask. And she went to her oncologist, and the response was, yeah, that'd work. And that stuck with me, and to this day, and I thought to myself, what if that person hadn't said that? What if she didn't have access to that knowledge, that hand-down knowledge? And that's what compelled me to believe that we will look at things like virtual care and telemedicine. But the other thing is, how can we really crowdsource? How do we decentralize the knowledge to a point where people can actually access it no matter where they're at and ask the questions they wish they should have asked? That pre-knowledge, I'm so passionate about that, because imagine all the questions and answers you went through in a very skilled way to get to the best outcomes. That should be handed down, right? That tribal knowledge.
Absolutely.
Can I interject here?
Please.
Yeah, so now you're into my passion.
That's what just should be, is passion driven.
I don't want to take all the time, but this is what I'll say. So what you said, what both of you said, is like, music to my ears, because I really am an advocate of getting the patients the information that they need. Here's the challenge. You go online, there are very good sources of information, right? NCCN, ASCO, there are all of these patient sources of information. But when you are an overwhelmed patient, right, how do you get through the volume of information to know what is pertinent to you specifically? The example you gave was a very specific situation. And, to no one's surprise in the audience, and if there's any oncologists there, anyone who knows me within 1, 2, 3 degrees of separation gets a cancer diagnosis, and I get a text or a phone call. Totally fine, because we talk about exactly what's going on, and I kind of do the same. Okay, well, ask about this, ask about that. So for me, the challenge is, how do you get the right information to the right patient and at the right time? Because the other thing that was a pet peeve in clinic is, when you start a patient on a treatment plan, they get all of the information that they need about, toxicities and survivorship and what's going to happen a year from now in a big binder or a folder, right? But when that person needs it at, 2 a.m., when they're actually having the vomiting, how do they get through all of that to get it when they need it, right? And so for me, the challenge is helping patients get what they need and at the right time. So.
And the opportunity with the increase in patient engagement, the digital tools, the asynchronous communication with the clinician. Absolutely. So
that, to me, I can talk about this, the social aspect of it too, because I truly believe in the peer-to-peer knowledge sharing and the idea of mentors, survivors and those in remission, mentoring newly diagnosed and handing down that knowledge. I also think and transitioning a little bit to the structural employer policy side of it. When I first started at the American Cancer Society, it was this big debate between interventions versus structural policy change. And I was very naive and young, and so I wasn't sure. First of all, I wasn't sure what any of them meant, because there was definitely smarter folks than I working on it. And then I learned, and what policies need to be put in place, or did the pandemic stir and put in place the policies necessary so that this becomes scalable from a digital health perspective? Are we seeing employers gravitate more towards covering it in their benefits? Are we seeing, where does prevention play a role? That's one thing that Cole and I were talking about today. I'm so passionate about prevention, but we don't talk about prevention a lot because it's hard to put prevention into an intervention. I didn't mean for that to rhyme, but it's hard to put prevention into an intervention that's digital. There are pictures out there. I did dress up as a Polyp Man in the early 2000s as part of an ad. You probably remember that. The American Cancer Society and the Ad Council. And I would go to work sites and I would literally be dressed up like a big polyp, and then I would be advocating for colonoscopies at the work site. That's not a scalable digital intervention. It was funny for a lot of people to watch me, breakdance and whatnot in a polyp suit. But how does prevention also leverage this? Because I do believe primary prevention, not just sort of diagnosis on, is important. So who would like to talk about prevention and benefits and structure?
Yeah, I can chime in there. So the first step in prevention is just making sure people are aware of what they should be doing in order to minimize the likelihood of getting a cancer diagnosed, or if they do, making sure that they're getting diagnosed early. So one thing that we do in MSK Direct is we simply have a digital tool where people input some basic information, and it is able to spit out a personalized set of, is that better?
You had to closer.
Okay. A personalized set of recommendations. So it'll say things like, you're overdue for a colonoscopy, or you're due for a mammogram, or you should probably be a bit more active or reduce your red meat intake. That's the first step, which I think can be very easily addressed with digital health solutions. The next step beyond that is, now how do you actually make it easy for somebody to get that colonoscopy, or to get that mammogram, or take action on those recommendations? How do you share that information with them at the right time to maximize the likelihood of that information being implemented in their life?
So that's exactly where you were headed with the prevention piece of, we've become so focused as a society on the treatment versus the prevention. We've become a little bit, in my mind, just seeing what we see at the differences in us in Australia, is that we've become a little bit complacent. Remember, I'm sure we all remember, you said Polyp Man, but tobacco is on the rise. We've kind of gotten a little bit complacent about reminding people that tobacco causes cancer. We have smoke-free environments, but still that's not out there. So it's, especially among Black youth, tobacco is on the rise. With our companies and working with we also have like 7 million lives covered too. We need to compare notes a little better because maybe we can double down on that. But so much of what our gold standard companies work with is personal health. Knowing what your personal health are, become your own advocate for your own self. So that way, if you need for your employer to cover a colonoscopy at the age of 35 because your mom had colon cancer, then you need to go to them and advocate for them, and they will pay for that. I mean, that's not a problem. We have not had any kinds of pushback on any of those. But then you have to think about, okay, so these are people that have jobs, that have great benefits. How do we reach and go beyond that? Reach the population of health that seem to be marginalized. So our companies, our gold standard member companies, are raising their hand and say, hey, look, we're gonna own that too. We're going to reach out to the community. We're not just going to be the employer. We're going to be an employer that is focused on the community where we live, work, and serve. And we're also working with, as you were talking about, messengers and that communication, that peer-to-peer. Digital tools are great, but if you go some places in Alabama and Georgia and Louisiana, there's more bandwidth in my cell phone than there's in the entire cell phone tower. So being able to pull down some of these apps is almost impossible. So we're actually working with historically Black colleges and universities and Hispanic serving institutions that are, if you look at the map, NCI designated cancer centers, 90% of them are outside the cancer belt of the United States of America, of which where HBCUs and HSIs reside. So we're working with them to make them hubs of information. It might be on the technology scale, it might be on the access scale, it might be on the social work, on the rehab, on the transportation scale. What is their role to be influencers in their community on good population health? Of course, we're starting and we're focusing on oncology, but we know if we focus on oncology, we can impact diabetes, we can impact heart, we can impact all the other critical care that's needed out there. And so getting back to that prevention piece, prevention is communication, having people have the tools. If each person doesn't have that tool, someone in their community has that tool that they know they can go to that site to get the information that they need to access what they need.
I would add just one more piece to the prevention aspect, and that is in cancer survivors too. So, you know, once patients finish the treatment part of it and get into survivorship, cardiovascular disease health is huge there, especially understanding what the interventions that they've had for their cancer, like certain chemotherapies and radiation, do to increase cardiovascular risk, which is, you know, the leading cause of death in the U.S. after all. And so a couple of years ago, we developed a tool for cancer survivors to assess cardiovascular risk. So kind of what you were talking about on the prevention side in patients who haven't had cancer, but it was for patients who had cancer to be able to put in what kind of tumor they had and then what chemotherapy they had, radiation, and then to say, here's what your risk of cardiovascular disease is, heart attack, stroke, et cetera, and what you can do to cut that risk. And so I think there's opportunity, you know, very early on in populations that haven't had cancer, but also in our survivor opportunities as well. So
I would add to that and suggest if we're able to get more upstream, you know, I think we can all appreciate that the American healthcare system is sick care and not health care, and lacks the opportunity for proactive care. And so certainly thinking about how do we reorganize and restructure and galvanize various communities and community groups to help with not only raising knowledge and awareness about particular diseases, but really transforming our interaction with health, our interaction with understanding, you know, some of the fundamentals. In addition to the leveraging digital tools, we, you know, I'm sure we can appreciate, we have to be cognizant of digital literacy and health literacy and how inextricably linked, those things are. And so to be able to decouple what that looks like and make sure that the programs that are being put into place take that into account is also something of high importance.
You know, one of the things this has been such an awesome dialogue. And if you think about virtual care, telemedicine, a lot of us have done this for quite some time. For me, I think my first kind of foray was at Walgreens with launching MD Live at Walgreens. All of that was really focusing on more episodic care. And then kind of, it started in 2013 or so, started seeing it evolve more and more and more. You started seeing more chronic condition management using virtual care, kind of hybrid care. At CVS and Aetna, it was kind of a mix of both. What I'm seeing now in oncology, though, is far beyond, I think, just virtual care and telemedicine. It almost has a richness of closing gaps in care, getting valuable services to the community, holistic care, the idea that there's psychosocial elements that need to be addressed and prioritized beyond treatment elements. So just in, we maybe take 5 or 6 minutes about talking a little bit about the outcomes and sort of why would we see the trajectory of virtual care or digital care, hybrid care in oncology go up. And for the audience, and you've probably been through several panels talking about employers in telemedicine and where's the ROI, or health systems in telemedicine, where's the ROI? 1%, the prevalence rate of a newly diagnosed patient in an employee population is about 1%. it accounts for 16+% of the claims costs for an employer and for a health plan. So the ROI absolutely is there, and there are interventions to reduce that cost using digital health. So maybe I'll start with MSK, because MSK did a study on RPM using an algorithm that saw 48% in a certain population reduction in costs. Can you talk just a little bit about that, and then the rest can share their story?
Yeah, we had a program called Insight Care, where we would simply send a questionnaire, a daily questionnaire out to our patients. They would respond. An algorithm would then be applied to the data from that questionnaire to stratify the risk of that patient being admitted to the hospital. If the patient was at high risk, a nurse practitioner would proactively contact that patient, understand what was going on, and help the patient figure out what to do next. Very simple program. This was not high tech. There was nothing revolutionary about this. We saw a 48% reduction in hospital admissions as a result of that, which also account for half of the cost of cancer care. Now, if there was, if there was a drug that could have those types of outcomes, it would be a blockbuster, multi-billion dollar drug. So sometimes these very simple, well thought out interventions can have a huge, meaningful impact.
Everyone else on outcomes, what have you seen? What are your shared learnings and experiences?
So from our standpoint, we also, as part of Nant Health, have a clinical decision support tool. So we are able to support treatment decisions and making sure that patients are getting the right evidence-based treatment. And, we found in our own studies that, again, simple stuff, right? Just being able to have patients on, what is known to be evidence-based and to be the best treatment for this particular person is also a way that actually returns ROI for our payer clients as well. So I agree with you, Cole. Sometimes it's just, simple, what we already have in place, making sure that we're able to apply that.
Absolutely.
Jasper, I'm going to jump in before you, because yours comment is going to be much more profound than mine is. But whenever the pandemic first started, over 300,000 clinical trials were halted worldwide. And I think oncology was in a unique space to mobilize quickly and quickly flip as these virtual trials into space, which I think has really been able to help the health industry capitalize on keeping that momentum going. One, you get greater access, you get greater consistency. The only real glitch that they had during that process was getting them the protocols in a timely enough manner. The transportation piece kind of failed, but I think that really helped pivot the oncology sector in a leading space in this digital. So one of the silver linings from the pandemic, that just from what we found, and we actually did a webinar that came online fairly quickly around virtual trials that helped to pivot. We worked with the FDA on that and helped to get that on stream. So I'll toss it to you, but that's definitely a case.
I'll add to that. I love that you brought that up. The idea of decentralized clinical trials was in existence prior to COVID, but certainly COVID allowed it to almost a mandate, right? You needed individuals to continue with enrollment in their clinical trials, and so it really increased acceptance within the pharmaceutical space and other sponsors. And so 80% of clinical trials during the peak of COVID of oncology-specific trials went into a decentralized manner. And a good deal of those learnings, I think, was the opportunity to increase the access to care, increase the number of individuals, and diversify the groups of individuals who were enrolled in clinical trials. And obviously, we can understand that if there are opportunities to participate in clinical trials, especially late-stage cancer, that in itself can help promote increase outcomes, improved outcomes. I would also say that for variations in digital tools. So for instance, remote patient monitoring, or the ability to have that consistent contact with the patient, patient engagement tools for side effect management, that increases adherence. That has been shown to decrease emergency room visits, to increase the opportunity to leverage various medications for pain outside of opiates, and allow individuals to stay on treatment longer and have improved benefit and decrease in cancer recurrence from that as well.
And spoiler alert, the next panel that our distinguished colleagues are going to speak on is a little bit about that. So you can, after this, follow them to their panel and get more detail.
Down the way and around the
Yeah, it's a run, but that's how you get your steps in. So there's like a physical activity component of it. So for the last, I would say 8 or 9 minutes, I really wanted this panel to have some takeaways for the audience. What are 3 things that each recommendations from experts you can do either in your organization or advocate for other organizations to do to really kind of help drive or accelerate this idea. This is a very big idea to me. This idea that hybrid virtual care, it's not just another type of telemedicine. This is going to be a new way we tackle one of the biggest problems in health, period. And we are truly at the cusp. I mean, it is something that I believe is going to be the biggest thing because, for one, it's helping patients at scale, and hopefully, I always say, delivering empathy at scale, because you can't do all virtual, all bots. Bots don't do empathy. Ever try to do a ChatGPT test and try to get an empathetic response? You can tell it's still ChatGPT. You need to have humans in a hybrid approach. So as we see this evolve, this evolution, I would love each one of our colleagues up here to give 3 things that they think either you could do or we should do to move this industry forward faster.
Absolutely, Adam. So thank you. I would say one thing that we haven't touched on, which we absolutely should, is the workforce optimization, the ability for digital tools to be thoughtfully placed into the clinicians to help improve the workforce. We all can appreciate that oncologists specifically and specialists in general, there is a huge shortage and it will continue to get worse with time. And so are there ways in which we can create efficiencies in the system with digital tools to help to improve workflow and workforce optimization? And then I would add, if we're able to design, as we're creating additional processes or ways in which hybrid care can work, leveraging digital health, we need to keep that lens of health equity as well. And if that is at the forefront of the design in the beginning, then we're really creating an opportunity to capture better health care for all. And so those would be the 3, the workforce optimization, the workforce efficiencies, and then the health equity lens.
I'm glad you gave me that introduction because I was going to talk about health equity. We touched on it a little bit here, but I think what's important is that we're at a point in health equity now where we have a lot of research about differences, and we have a lot of look backs. And I did those studies too, where it was called disparities. It still is kind of, but it was just to look back on, okay, here's who doesn't do as well in X, Y, or Z cancer. And so we know that, and I think that now we're at the point where when we're thinking about systems, we have to include that up front, right? I don't think it's good enough anymore to roll out, an app to a patient population or start a new venture, and then 2-3 years down the line, we just look back and say, okay, well, here are the people who didn't do as well. And so, I mean, the data's there. We know about differences in rural versus urban populations. We know about, underrepresented minorities. We know about the elderly. So just thinking about those populations as we build solutions is one. The second, I think, is if you're going to do that work to really partner with the communities that you're trying to serve, and I think you touched on that as well. But I was personally surprised about what you learn when you actually involve the patient in the conversation. And with my own sense of, inflated ego, probably of, I'm a breast cancer academician who, works in underserved populations. So I know everything. And then, just talking to patient advocacy groups and talking to patients, I'm learning a whole new area, right, that I had taken for granted. So I would say making sure the patient's voice and the community's voice is at the table when you undertake those efforts as well.
I just real quick on that. I think that's so powerful because we overestimate how prepared folks are for hearing the news you have cancer. We overestimate what they probably already know. I had one of our patients, our members, was when a coach asked, well, shouldn't Medicaid take care of this for you? And the member said, what's a Medicaid? That there, right? I mean, we cannot anticipate that our members, our citizens, our friends and loved ones are as astute in healthcare as we are when we're building these products. I think that's important.
And I think I have one more, and that is to, we touched on that as well, focus on, there's simple things that we don't do well yet. So there's gaps in screening. There are gaps in lung cancer screening, right? I mean, the uptake of screening CTs when they are warranted based on a smoking history is abysmal based on the states that you're looking at. And so, often we get into these very high-level technical discussions about the newest, coolest thing, but I would really like to see these tools used to get the simple, not simple, but the simple stuff that we already know about to get that right.
Besides joining the CEO roundtable, actually that can be 1, 2, and 3.
That's right.
There you go.
So I'm instead of echoing what they said, because that's all definitely in alignment, but we're all in alignment here. I'll just add on, instead of adding 3, I'll probably just add maybe 1, maybe 2, if we break it down. Certainly having employers take on a more analytical role of what their employees and how their employees are utilizing their benefits packaging. And one, making sure they are utilizing it, and encouraging them to utilizing it, but also taking it a step further and then utilizing that data to go to the payer, if they're not self-insured, go to the payer and help drive down these costs. Because the cost incurred is not going to the physician. The cost incurred is going somewhere into the system. And the only way that we get those numbers down is for these employers that are paying those freights to step up and raise their hands. So I think that's an issue that we can take up with our fellow members, our fellow Gold Standard Accreditation, your employers that you have, to really sit down and have a real big conversation on what it's going to take to, I hate to use this word, regulate in a good way, right? I mean, regulate it so people get quality care without financial burdens. And the inheritance of a financial burden with a cancer diagnosis is out of the chart, with or without health care. So certainly asking our employers to take a bigger, stronger role in helping to shape policy on the Hill that can impact cost, and then also asking them to look at their own employee health more strategically, not just related to the cost savings, but related to their own employee health as it pertains to, are they utilizing their resources and encouraging them to take those opportunities to utilize those resources.
Awesome. Cole's going to take us home. His number 1 is, if your employer doesn't have MSK Direct, give them a call. And now go for the other ones.
So other ones. Number 1, don't let the complexity of oncology scare you away from building digital health solutions. I've got to imagine if this session were on a less scary topic, there'd be 4 times as many people.
That's right.
In this room.
You are the brave few that came in.
So you've already taken the step by showing up. 2, if you identify a problem in cancer care, and there are countless, just start working on a solution. You don't have to have a multi-million-dollar budget. You don't have to have a all-star technology team, do a pilot, partner with one of the hundreds of technology vendors that are at this conference, and get something off the ground, and then iterate and build from there. And then I'd say the third thing is employers play a tremendous and critical role in the quality of healthcare. I mean, they're the ones that are ultimately paying for healthcare. And I assume almost everyone, if not everyone in this room, is employed by an employer, works for an employer, plays some sort of role at that employer. And regardless of what your role is, think about what you can do to make sure that yourself and your coworkers are receiving the best care and support that they can. So that starts with understanding what your benefits are. Maybe if you're a manager, take courses on how to support the employees that you manage that may receive a cancer diagnosis. If you work in the benefits space, think through your benefits and make sure that you're doing what you can to really provide the support that's needed when one of your employees receives that devastating diagnosis.
Well, thank you, everyone. Let's hear it for this all-star panel. I would love to take questions, but we're out of time. So if you have any questions, please follow them to their next panel, and you can ask after that. Thank you very much, everyone.
Thank you, Adam.
Thank you.